Hello, this is Jaideep Chaudhary and it's dengue in a nutshell. So, whenever there is dengue, there is panic, there is urgency. The parents often insist on admitting a child who is dengue positive. Now, which child to admit? Definitely, if it's an infant, if the child is having comorbid conditions, if there are warning signs, if it's a severe dengue, and if the parents are unable to manage hydration at home. Regarding the warning signs, if the child is having abdominal pain or tenderness, if there is persistent vomiting, there are clinical signs of fluid accumulation, there is mucosal bleed, if the child is lethargic or restless, and if there is liver enlargement of more than 2 centimeters. Among the lab parameters, if there is increase in hematocrit with rapid decrease in platelet count, these are the warning signs, and definitely the child needs admission. NS1 antigen is a very common test done for dengue. It's a highly conserved glycoprotein of dengue virus which is secreted in the circulation. Initially there is viremia when the NS1 antigen is positive. Then as the disease progresses, it declines and then the antibodies become positive. The specificity of NS1 is nearly 100%. Sensitivity in the first 4 days. In primary dengue, it's 90%, and in secondary dengue, it is 70%. If we correlate NS1 antigen and the IgM and IgG antibodies, if NS1 is positive, it's an early dengue, less than 4 days. If only IgM is positive, NS1 may be either positive or negative, it's a primary dengue. If NS1 negative and IgM positive, it's a current or a recent infection when IgG may also have a low titer. If IgM positive and IgG is having a very high titer, then it's a secondary dengue. And if IgM is positive and IgG has high titer, then again it's a secondary dengue. And if NS1 is negative, IgM is negative, and only IgG has low titer, it signifies a past infection. When a child with dengue is admitted, we have to start with isotonic solution only, preferably normal saline at 5 to 7 ml per kg per hour. See for the improvement. If the child improves, then we have to decrease the IV fluid accordingly to 3 to 5 and further. And if there is clinical improvement, we can reduce IV fluid further and may stop after about 48 hours. If there is no improvement, then definitely we have to check the hematocrit. If the hematocrit is low, we decrease the fluid accordingly and may stop after about 48 hours. But if the hematocrit is high, then we may give a challenge with normal saline of 5 to 10 ml per kg over 1 to 2 hours. If there is improvement, then we reduce the fluid accordingly. If there is no improvement, then we again check the hematocrit and go back. Regarding monitoring urine output, a pulse volume, the dorsalis pedis artery is a good artery to palpate. Blood pressure, hematocrit and platelet also all needs to be monitored, but clinical monitoring is more important. When to stop IV fluid? Definitely when there is signs of cessation of plasma leakage, when the BP pulse and perfusion are stable, hematocrit decreases in presence of good pulse volume, the child is afebrile for 24 to 48 hours without antipyretics, the bowel symptoms and abdominal symptoms are resolving, and definitely when there is improving urine output. So thank you. See you again.